I became a physical therapist a long time ago and didn't really like it. So I went to graduate school, got my PhD, and then started doing cerebral palsy research. I started Neuromuscular as a sub in Jerry Mendel's lab. He needed someone to cover till he could hire someone. 15 years later, haven't looked back. So it was an accident, but love it.
I did my undergrad physio degree in Sydney. I'm Australian originally, but now work in England. And like many young Australian healthcare professionals, I wanted to travel the world. And so I went to the United Kingdom and ended up in a grown-up muscle job in Oswestry first of all, and then moved up to the Newcastle team. And that has been a source of great mentorship and led me to my position now.
Yeah, so I did my my Doctor of Physical Therapy practicum with Tina Duong actually at Children's National in Washington, D.C. And so I spent the summer with her and thought, wow, that's an interesting job, but I don't want that for me. And then I came back and I did a pediatric residency. So I got a flavor for a lot of different parts of physical therapy. Linda was actually my research mentor. And I found that I surprisingly enjoyed the research portion of that residency more so than any other part. And so well, of course,
yeah.
So I kept looking for opportunities to get into more and more research. And then she got in and working with Jerry Mendel, and then a part-time position opened up. And I said, I don't know. What will I do in a career of pediatric neuromuscular disorders? And then 15 years later, here we are.
Don't take no for an answer. That nothing is set, nothing is easy, and you won't get it if you don't want it.
Absolutely, yeah, sheer determination. But I also think it's really important as a young physical therapist to go and get some broad experience to understand what it is that brings you passion in your job. So it may not be neuromuscular. Whatever you have a passion for is where you should strive towards and get lots of experience in different environments. I really enjoyed working in a big city, but then I went and worked really remotely in remote Aboriginal communities and flying doctors, and I did some international aid work, and then I came to the UK. And so I think that broad experience to understand what really drives you, because if you're going to undertake academic pathways, you need to have a true passion for what you're doing.
Absolutely. There is so much that we don't know and want to know more about and could create and develop and collaborate. There are so many opportunities. I think this field is growing exponentially. Again, it's kind of seizing the opportunities as they arise.
But I think what's different about us is most academic PTs work in school. They teach and do research on the side, but we are purely clinical researchers, no teaching. And so you can become a researcher in diverse settings. If it's something you love and you're interested in, you can become a researcher anywhere.
I think the beauty of what we do being clinical academics is your work is all patient-centred, so everything we do is driven by our patient care, and that I think is the beauty of doing a clinical academic job, actually seeing our research translate into better outcomes for our patients.
And just answer with why, or why not. Don't take an answer, you've got to question what brought you there. My big thing right now is mentoring young physical therapists and helping them find the opportunities. It took me a very long time to get where I want to be, and so the next person has to be easier for.
I would like to continue to have the opportunities to do the research we'd like to do with a lot of, we've done it as a collective, we've done a lot of outcome measure research, but actually in the absence of pharmacological treatments for our patients, the therapy of what we do isn't heavily researched, and we need to do a lot more work about the things we prescribe patients and develop treatment plans with our patients and see what works from a practical physical therapy point of view.
I would say I'm really excited for kind of PT-driven collaborations and growing our network and continuing to drive our projects forward across the globe. So I think we do have a nice neuromuscular network, but really continuing to bring that neuromuscular PT network into the leadership roles.
You know, it's very important within our field that we characterise disease and we understand disease progression and we become trial ready. And I'd like to see that what we are developing in conjunction with our patient cohorts is actually reflective of the difficulties they come to us with, so that we've got scales that reflect lived experience of the disease but are also robust enough to be endpoints in trials, and something that might potentially change in a trial that's meaningful for the patients.
And I think figuring out what you should measure, it's kind of like being a detective. It's a rare disease. We don't really know how they change. We don't know what's meaningful to them. We don't know how to measure it. So based on the mechanism of action of the drug, the time, the age of the people, you can come up with a very specific, tailored outcome measure rather than just using something standard that doesn't fit. So it's exciting to learn the details and find something that's really fit for purpose.
I love the math. It is so exciting. You listen to the patient. They have something that's bothering them. We figure out how we can measure it, and then we gather a bunch of data, and then we get to graph it, and the answer just appears, and it's, oh my goodness, this is what they've been telling us. I love bringing that whole puzzle together.
I think we work to make sure that we measure the patients with something that matters. And so if we have a measurement that matters to the patients in the trial, that's a great outcome, rather than measuring things that aren't necessarily important to the patients.
We're listening to the patients. As Meredith said, we're creating a scale that is meaningful to them. It's what they're telling us, and then to get to see it then hopefully measure improvement or maintenance of function over time in a trial is really, I hope, empowering for patients as well.
This is not something we develop when you're ready to do a trial. This is preclinical work. If you have a mouse model, you contact me so I'm ready when you're ready. People think, oh, well, now what do we measure? And it needs to be a process. So I think that's what I want to get across most, is that this work takes a lot of time, and you need to give us time, and it needs to be funded. And I think too many people use it as an afterthought. They've got first in human, and they're thinking, ooh, it's a safety trial. What else should we measure? And that's not going to work. We don't have all the tools.
No, we've got lots of
We're
work to
working
do.
on new diseases, new treatments, new lengths of time. If you're going to dose in infancy, how do you figure out whether they're new without waiting till they're 3? We're on to the next one. There's no perfect trials. It's always really tailored, and there'll be more and more as long as we're still finding new patients and new treatments.
Changing trajectories, different timing of treatment affects those trajectories. I think, we've learned that as treatments come on the market now, tools that maybe were great and robust and really meaningful in the past no longer measure our new patients. And so it's, I think we have a job for a while.
I think we'll be okay.
Yeah.
We've also got a lot of the world that we haven't even looked at. We've got a lot of unreported patient cohorts outside of our usual neuromuscular networks that we need to go and understand and work with the clinicians in those countries to characterise much more ethnically diverse cohorts.
And drive standard of care
And
and
drive
elevate.
standards,
Yeah.
yep.
With treatments that are really working well now, that are changing the clinical phenotype, the old tools no longer work anymore. So SMA is a great example. We were measuring little infants that were deteriorating, and now all of a sudden they're doing things we've never seen before. So even though the old tests are validated, they were well constructed, it's a completely different disease, and so we need to move on. And I think that's hard to say, my old work is no longer applicable. I need to move forward and find something changing. Everything changes, and that's exciting.
Yeah.
That's exciting. It also creates a lot more work, but it's an exciting problem to
Good
have.
thing we like to work. Yeah, so I think the pandemic really pushed us to develop these kind of telemedicine skills. I think I'll speak for myself, not for you all, but I was a little bit hesitant. I didn't think it would be as effective. I think, to your point, having our hands on patients, being able to guide kind of movements was how we were going to get best outcomes. But we've seen, in our research that we're able to capture these really robust assessments in the home environment. We can actually see patients where they are. We don't have to make them come to us all the time. I think there's also opportunities to kind of merge assessments as well and use both, our skill set as well as other tools that are becoming available as technology continues to grow and expand. But I think it will continue to take our expertise to make sure it's meaningful, robustly constructed, and actually is measuring what we think it's measuring.
I think the pivot to the remote and telemedicine during COVID was difficult for our patients and their families, but also the contact, having video contact while families were shielding for months on end was really important for everybody that they could see clinicians and have those conversations. It gave us a new opportunity to see the home environment. We're not often in doing home visits, so to be able to see patients at home and have those conversations about what things they did have at home. Does the sofa need some blocks under it because they're struggling now to get out of the sofa? We worked really hard on trying to standardise assessments in the home. Some assessments just don't translate. And that's also, we have to be mindful that if we are assessing in the home, there's a burden then on the parents or the caregivers as well to do that assessment with us live that isn't in the clinical practice. So there's a lot of things to consider. There's pros and cons for all of it. I think telemedicine should be more routinely utilised, especially for families that might struggle to come into clinic regularly or travelling from a distance, or the level of disability makes getting in the car and travelling for a few hours really, really difficult.
I think the goal of a lot of our assessments is to expand access to more people, so to expand the recruitment pool because we work in rare diseases, but also trying to give everyone a chance to participate. It was interesting, though, some people really liked the remote assessments and some people really missed coming in. And so I think it's just another way to offer a choice. You can't make someone adapt to remote access, but you give them the option, and you also give them the option to come in and see you. That's what I think the problem is. There's no answer. It's not, can we see everyone remotely? Is this how we're going to do it? I think we have a lot of tools that we cater to the individual needs. Internet access isn't equal across the board. So there won't be a shift to entirely digital outcomes. They'll be incorporated, but we'll never get rid of in-person. And who knows what's next?
And I think it's important. We can have a variety of metrics. So there may be things that are better in the home and things that are better delivered in a standardised way in a centre where everything can be standardised. But the access to digital technology and comfortableness with digital tech is also, this is not an equitable thing across the world either. And certainly during our lockdown periods when we were doing a lot of remote assessments, families might not necessarily have enough devices or have enough bandwidth to be able to conduct a remote assessment. So we need to make sure that we give people options of both and do what fits with what they need.
And I can even think in our trials, thinking through our different patients and family dynamics, it worked really well for some, and it did not work well for others. And so, to Linda's point, giving the patients and families that choice and providing that best option in a trial, and having the flexibility in a trial design or a clinical environment to be able to meet the needs of the families, I think it is really what's important.
And I think when we come out of trials and when we're just looking at our ongoing clinical service for our families, there's some things that just cannot be done remotely, like orthotics clinics or trying out some new equipment or looking at differences in seat heights, things like that. So some of that practical therapy type treatments that we do need to be done in person.
It's
It's
huge.
about time.
Yeah, it's huge. So we were just talking about this last night in our evening reception. It's been mind-blowing to have, I guess, the opportunity. As Linda said, you have to push. Nothing is set in stone. I think when Chris and I had this crazy idea, we did have to push and ask in a few different ways before there was a big yes. But just having the opportunity to have a session on exercise, nutrition, and lifestyle, we enjoy learning about new genes, new case reports, those sorts of studies. Zebrafish, we love zebrafish. But I think, it's great to have, really kind of a physio session. And even yesterday in our first session, we actually had 3 physios on the stage, 2 presenting and 1 moderating. And I think, representation really matters. And the only way we see that is if we have the opportunities to kind of lead and contribute. So I'm hopeful that this is the first of many.
Absolutely, and we've had a lot of strong mentors for us all that have allowed us to get to this point. So we had some incredible women who were neuromuscular physios and still are, who have paved the way to make the journey a little bit easier for us, and to have that recognition that we have a really unique skill set as outcome measure specialists who are completely driven by our patients' experiences and want to improve outcome measures for clinic but also for trials, and to ensure that everything we do has some meaning for the patients to it. Yeah.
I think change is never easy for any one or any group, myself included, when there's new things that don't really fit into what your perceived perceptions. And I think this is exceptional for the WMS to accept this growth. Some great men started it, and it's hard to let go, but it's time to broaden it, and it's time to give new people opportunities, and it won't diminish from the original founder's stature. It'll only allow them to shine more because they've mentored this whole group, and it's time to move forward and to accept all kinds of diversity, and it'll make the organization stronger.